with me today is Professor Joyce Mack, and I'm Hazen Chen. So to start with, I'm going to go through something conventional about colorectal cancer screening, and later Professor Joyce Mack will talk more about on the advances of colorectal cancer screening. So first of all, why do we need colorectal cancer screening? As you can see from here, this is actually the latest data released a couple of days ago from the Hong Kong Cancer Registry about the cancer incidence in Hong Kong in 2019. And you can see, although lung cancer has just replaced colorectal cancer as the number one cancer in Hong Kong, colorectal cancer is still the number 2 cancer in Hong Kong. Apart from being very prevalent, you can also see that the mortality from colorectal cancer is actually very high. It is the second leading cause of cancer death in Hong Kong. So you can see that it is both common and a deadly cancer in Hong Kong. And what's more important is that you can see from this data published by Dr. Rashid Lui from our team, the young onset colorectal cancer is on the rising trend, both rectal cancer and colorectal cancer. You can see for those who have cancer age below 50 is rising. And the good news of colorectal cancer is that it is preventable and also treatable. But there is a very big but here. It is only treatable and preventable if there is an early and accurate detection of the disease. So we are talking about colorectal cancer screening. So what actually is screening? I think most of you have gone through your family and community medicine module last year. And if you remember, screening is to detect early disease or risk factors for disease in a large number of apparently healthy and asymptomatic individuals. And the goal of screening is to reduce mortality through a reduction in the incidence of advanced disease. And why is colorectal cancer a very typical example of disease that we can screen for is that it typically originates from precancerous colorectal polyps. And this usually takes around 10 years to develop from a polyp to carcinoma. With this long latent period, it provides an opportunity for the prevention of if the lesion is actually detected early and successfully excised. So for screening, actually there are 2 types of screening method that we can do for general for whatever diseases that we're talking about. It can either be opportunistic screening or population-based screening. What is meant by opportunistic screening is that it so happens when an individual comes to the doctor and asks for a test, like this meaning here, looking at you and asking for a specific test. Or we see a patient, when the patient comes to see you, you take that opportunity to provide or to offer a test for the patient to screen for a particular disease. But this type of opportunistic screening cannot provide coverage to all patients. So what can we do if we want to have a population-based screening? Is that we need to offer a systematic test to all individuals with symptoms in a defined target group, like all the meanings here that we're going to provide the screening for, rather than they coming to you or you offering the test to them when they approach you. So the population-based screening needs a systemic way to provide the test to all individuals without symptoms in a defined target group. So coming back to colorectal cancer, so what are the ways that we can screen for this specific disease? For colorectal cancer screening, as you may appreciate, we are talking about cancers from the large bowel. And from the large bowel, there's always stool in it. So we can use stool-based tests for the colorectal cancer screening purpose. We can go into more detail about the stool-based test here. But the other way is by imaging, either by direct visualization through endoscopy, either by sigmoidoscopy or colonoscopy, or we can also visualize the colon by radiology imaging technique like CT colonography. So first, stool-based test. There are several stool-based tests that we can talk about. The first one is the more traditional one called the guai-based fecal occult blood test. This is the FOB that we used in the past. How we can apply this test is that hemoglobin is identified by the presence of a peroxidase reaction, which turns the guai impregnated paper blue. So meaning if there is occult blood that is present in the stool but cannot be visualized, this guai-based fecal occult blood test can be able to detect this blood which cannot be detected by human eyes. However, usually blood is only present when there is large lesion, for example, cancer. However, for small polyps, there may not be blood in your stool, and therefore, this test is only for detecting cancer, but not a good test for polyp detection. And in the older version of the guai-based FOBT, you can see that the sensitivity is actually rather low, of around 30 to 40% per single test. The newer version raises the sensitivity. However, it is still only around 64 to 80%. There are studies to show that if you do a systematic guai-based fecal occult blood test to the general population, it may help to reduce the colorectal cancer mortality. However, this test is not perfect. Apart from the limited sensitivity we have discussed, there may also be false positive results. For example, if you eat something contains a lot of blood, like if you are eating a lot of red meat, it may give you a false positive result resulting from the blood, not from yourself, not from your stool, but from what you have eaten. And when there is a false positive result, it may create unnecessary workup for the patient. If you are really employing this test to screen for colorectal cancer, because we have mentioned that it is not good for polyp detection, it's only good for cancer detection, we recommend annual screening if you are using guai-based fecal occult blood test. For stool-based tests, apart from the traditional guai-based fecal occult blood test, there's another test called FIT test, fecal immunochemical test. This is actually the preferred cancer prevention test that we are using nowadays. So the FIT, how does it differ from the guai-based FOBT? It only responds to human globulin. We've mentioned that if you have eaten a lot of red meat, you may cause a false positive result for the traditional guai-based FOBT. But when you are using FIT test, the FIT test, because it only responds to human globulin, what you eat will not create a false positive test for having a lot of other animal blood. But bear in mind that it is only good for detecting blood in the lower GI tract. Do not use it for other purposes. For example, if you are suspecting a patient having upper GI bleed, do not use this test to confirm whether the patient is bleeding. Reason is, the FIT test is to detect human globulin. But if the blood is from the upper intestine, actually, when the blood is passing through the upper part of the GI tract, the blood will be, the globulin in the blood will be digested in transit, resulting in a false negative result. So the FIT test is actually only licensed for detecting blood in the lower GI tract and licensed for screening of colorectal cancer. There are meta-analyses to show that FIT test is quite sensitive in detecting colorectal cancer in asymptomatic patient with a pooled sensitivity of around 80% and a pooled specificity of around 94%. And similar to guai-based FOBT, if you use FIT test for screening purpose, the recommendation is to do annual screening. How about these two comparing together? So you can see here that the FOBT sensitivity in detecting colorectal cancer is around 33%, while different type of FIT has a much better sensitivity in detecting colorectal cancer, ranging from 53% to 73%. Likewise for the specificity. The sensitivity is even lower if you are talking about other so-called advanced neoplasm, for example, large polyps. So it is best in detecting cancer, but not polyps. Apart from the FIT test and the guai-based FOBT, we can also use the stool test for DNA testing. Why can we do that? Because there are altered DNA from the adenoma or carcinoma. And usually this altered DNA from the colonic adenoma or carcinoma will be shedded and can be detected in the colon. As long as you have adequate stool sample from obtained, you can actually detect these altered DNA from shedded from the adenoma or carcinoma in the stool. And the sensitivity and specificity can be very high, with nearly 90% or sensitivity even more than 90%. But this test may seem to be very effective, very sensitive, and very specific. But the problem of employing stool DNA testing is that the cost is significantly higher than the guai-based FOBT and also the FIT test. So this limits the use of stool DNA testing as a population-based screening tool. And also for the screening interval, by now there's no consensus of how often do we need to employ the stool DNA testing to screen the patient. But when compared to the FIT, you can see stool DNA testing is much superior, especially for the early stage. You can see for stage 4 disease, they may be comparable. Reason for stage 4 disease, usually the blood will be more and the FIT test may perform equally good. But for the early stages disease, or even for the adenoma, the stool DNA testing has a superior performance as versus the FIT test. So having talked so much about stool-based test, we can also use visualization of the colon as a test for colorectal cancer screening. And obviously, the best tool for screening colorectal cancer will be colonoscopy. We call this type of test a cancer prevention test because for the stool-based test, especially the FIT test and the guai-based FOBT, we've already mentioned several times that it is only good for detecting cancer, but not for polyp. But when we directly visualize the colon, we can even detect polyp. And once you detect polyp, you can do polypectomy and to take away the polyp and prevent the cancer from forming. And for colonoscopy, you can visualize the whole of the colon so that you can prevent the polyp from getting into cancer. However, when we do colonoscopy, it is still an invasive test. You may cause complications like perforation, precipitating cardiovascular events, and also the patient needs to cleanse his bowel before proceeding to colonoscopy. You need to ask the patient to have no residual diet, followed by fluid diet, and the patient also needs bowel cleansing agents for the bowel preparation before colonoscopy, which can be quite cumbersome to many patients. If the colonoscopy is normal, and if the patient has normal average risk of colorectal cancer, actually we recommend screening interval with a 10-year screening interval. Meaning, if you have a completely normal colonoscopy, if you remain asymptomatic, you only need to repeat the colonoscopy examination 10 years later. So as we've just mentioned, the reason why we call colonoscopy a cancer prevention test is that we can detect polyp, and whenever we detect polyp, we can do polypectomy and cutting the polyp from becoming a cancer in a later stage. And you can see the colonoscopy with polypectomy can result in a 53% reduction in the colorectal cancer mortality in a very large cohort study. So you can see colonoscopy is the most effective test in preventing colorectal cancer. And you can see here with the screening colonoscopy in various countries, the relative risk reduction in colorectal cancer incidence can range from 30% to up to 91%. and the colorectal cancer mortality is also significantly reduced. So we can also do flexible sigmoidoscopy. As the name implied here, in contrast to colonoscopy, where we will examine the whole of the colon up to the cecum, for flexible sigmoidoscopy, we are interested in the distal colon only. Usually, the examination is from the rectum up to the descending colon. As we do not need to examine the whole of the colon when we do flexible sigmoidoscopy, the patient will require less stringent bowel preparation. Usually, fleet enema 1 tube before the examination will be suffice for the purpose of flexible sigmoidoscopy. And the patient does not require sedation when doing flexible sigmoidoscopy. But at the same time, if we detect anything in the flexible sigmoidoscopy, we can still proceed to polypectomy. But obviously, the downside of having flexible sigmoidoscopy, despite you do not need a stringent bowel prep and do not need the full colonoscopy examination, is that right-sided lesions may be missed if you are doing flexible sigmoidoscopy, because after all, you are not examining the transverse colon, the ascending colon, and also the cecum. And if the patient has polyp in the distal colon, it means that there are chances that you may still have other polyps in the more proximal part of the colon. So we will also suggest if the patient has polyps detected in the flexible sigmoidoscopy, they will require full colonoscopy at the end of the day. For this purpose of colorectal cancer screening, if you're doing flexible sigmoidoscopy, then we will suggest a screening interval of every 5 years, even if you have a normal flexible sigmoidoscopy. And you may ask, so how do we reduce the risk of missing proximal lesion in the right side of the colon where the flexible sigmoidoscopy were not enriched? Then I will suggest you to combine the 5-yearly flexible sigmoidoscopy together with an annual either fecal occult blood test or the FIT test to make sure you don't miss advanced lesion in the right side of the colon. And you can see here, if you do flexible sigmoidoscopy versus a control, we can reduce the risk of colorectal cancer development in oocyte, the mortality, and also especially the distal part. But obviously, because you're doing flexible sigmoidoscopy only, you might miss those right-sided lesions. Therefore, for the proximal cancer prevention, there is actually no particular advantage. Colonoscopy and flexible sigmoidoscopy are both invasive procedure where an endoscope is required to insert into your colon for direct visualization. But we can also employ radiological technique. For example, CT colonography is actually an alternative to invasive endoscopy as a screening modality. The good thing about CT colonography is that it is non-invasive because you don't need to put a tube into the patient's bottom. And it can still visualize the entire colon. And it actually has a very good detection rate of cancers and also large adenomas of more than 1 centimeter. The quoted sensitivity is actually around 84 to 94% for adenomas greater than 10 millimeter in size. However, for CT colonography, it still requires the patient to undergo full bowel preparation. And also, if you detect anything abnormal from the CT colonography, we want to prevent the cancer and you want to get biopsies. So after all, for those patients with abnormal CT colonography, they will still require a full colonoscopy. And CT, as the name implies, there will be radiation exposure. But if you read all the textbooks, they may mention about double contrast barium enema. For the radiation exposure of CT colonography as compared to the traditional double contrast barium enema, the radiation exposure is thought to be less. And one thing about CT colonography, despite we've just mentioned the sensitivity of detecting cancer and also large polyps, large adenoma is pretty high. But for flat lesions, it is easily missed on CT colonography. It is usually reserved for patients who have incomplete colonoscopy. For example, if the patient comes in for colonoscopy for colorectal cancer screening, but somehow they may have difficult sedation or technical difficulties where we cannot complete the examination, then CT colonography will be a very good modality for us to complete the examination of the colon. The suggested screening interval for CT colonography is 5 years. Another newer modality that we can employ to visualize the colon is by something called colon capsule endoscopy. As you can see here, we also call it a pill cam because it looks like a pill with a camera and light source attached to the end of the pill. And you can directly visualize, as you can see in the picture below, it can directly visualize the colonic mucosa, and you can detect both polyps and cancer. Actually, there are 2 cameras attached to the pill, both at the front and the back, so that you have a 360-degree view of the colon. As you might understand, that it is non-invasive and it is very accurate and safe. But because you still need to visualize the colon, if the colon is filled with stool, then you may not be able to visualize the mucosa. So like colonoscopy, the patient still needs full bar preparation when they're doing colon capsule endoscopy. And if you see polyps, because when you detect polyps on the colon capsule, then obviously you want to remove it to prevent the patient from getting cancer. So if you, like CT colonography, if you detect anything abnormal from the colon capsule, the patient will still require full colonoscopy for polypectomy or to confirm of lesion. There is one contraindication or significant risk of colon capsule endoscopy is that for patients who have previous GI tract surgery or in patients who have risk of stricture formation in the colon or in the intestine, then swallowing the capsule may cause capsule retention. So we will be very cautious or even consider alternative for patients who are at risk of capsule retention. For the optimal screening interval when using colon capsule endoscopy, there is currently no consensus of exactly when should we repeat the colon capsule. So you may ask, how do we retrieve the images from the colon capsule? Do we need to get the capsule to download the data like this cat here? If you have to do that, it may be a rather bad experience. So the answer is actually no, there will be a real-time data recorder of the images directly through Bluetooth or Wi-Fi into the data recorder. So you can review the images immediately and you do not need to retrieve the pill. Usually we'll just ask the patient to pass the pill and they do not need to search from the toilet for getting the pill again to download the images. So basically this slide summarizes all the tests that are available for the sensitivity and the specificity of colorectal cancer detection. So we know all the screening method, and the second question is, who should get screened? We've mentioned about population-based screening, but we still need to know who should be the target group. So actually everyone should get screened if they fit into the criteria. And now, as you may know, we are having a colorectal cancer screening program here in Hong Kong ourselves. And it was launched in 2014, and it is the first population-based colorectal cancer screening program here, which target Hong Kong residents aged 50 to 75 for those who are asymptomatic and for those who have no increased risk of colorectal cancer, which means those average risk population. In the screening program we are employing here in Hong Kong, it is a 2-tier system. What is meant by 2-tier system is that for those who are eligible to enter this program, they will consult a primary care physician. And the primary care physician will distribute an fecal occult blood test, which we're using the FIT test that we've just mentioned about. We will use the FIT test at the first tier for screening. If the FIT test comes back to be positive, then the patient will get a referral and receive a colonoscopy for confirming whether there's any lesion. But if the patient has a negative FIT test, then they will be rescreened in 2 years' time. So not everyone will be suitable to enroll to this program. Some we will actually advise them to go directly for colonoscopy, for colorectal cancer screening. For example, if the patient got symptoms for colorectal cancer, they should not get screened by fit test because they are symptomatic already. And by definition, they are not suitable for screening because they have symptoms, and they should directly go for the diagnostic test, which is colonoscopy. For patients who are at risk of colorectal cancer, the screening modality may also be adjusted accordingly, and they should receive direct colonoscopy. For example, those who have personal history of colorectal cancer, those with hereditary colorectal cancer syndrome, those with first-degree relative diagnosed with those syndrome, or those who have 2 or more first-degree relatives diagnosed with colorectal cancer, those who have the personal history of colorectal polyp, or those who have been previously advised against receiving colonoscopy will not be eligible to enroll into this program. On the other hand, some patients does not need to be enrolled in the program because they have lower risk of having colorectal cancer at that time point, because they might have received colonoscopy within the past 10 years with normal result. We've mentioned that the screening interval should be 10 years for normal colonoscopy, then there's no use to repeat it within such a short interval. Likewise, for those who have received flexible sigmoidoscopy within the past 5 years with normal results, and so also those received plain fecal occult blood tests in the past 2 years with normal result, then those do not need to repeat the test that early, and therefore not necessary to enroll in the program in this period of time. So far, there are 76,000 patients enrolled into this screening program, and around 13% of them has fit test positive required colonoscopy. And for those who required colonoscopy, around 70% of them had colonic adenomas. And among those who underwent colonoscopy, around 6% have colorectal cancer. And luckily, 60% of them were early colorectal cancer, which serves the purpose of early detection and hopefully resulting in reduced mortality. And actually, Hong Kong is not the only place who have where we have colorectal cancer screening program. You can see here for Japan, Korea, Singapore, and Taiwan, they all have screening program, and usually they are using fit test as the screening modality, and they have, because we have other considerations, the screening interval may differ countries to countries. So I'll pass on to Professor Joyce Matt to tell you when should we start screening and also some new advances in colorectal cancer screening modalities. So Joyce.
So thank you, Hazen. So our next topic will be when should we start the screening test for colorectal cancer? So as mentioned by Hazen before, our group, Dr. Rashida, has done a study which showed that the young onset colorectal cancer, that means that having colorectal cancer before the age of 50 is rising globally. And so recently, this year, the latest guideline from the United States saying that we should start the screening at 45 years old instead of 50 years old. So this is the updated US and ACG guideline in 2021. And previously, in the previous guideline, they only suggest adults aged 50 to 75 years old should undergo colorectal cancer screening. However, in the most updated guideline, they suggest that all adults aged 45 to 75 years old should undergo screening to reduce the risk of colorectal cancer. And then for patients who are very old, age 76 to 85 years old, the physician should discuss with the patient or with the subject and should see whether they should still proceed to having the colorectal cancer screening. So another very important point to consider is about the background risk of having colorectal cancer in the subject. So this is one of the studies from Professor Siu, which showed that the sibling of the patient having colorectal cancer actually has a 3 times higher risk of developing advanced neoplasm than the siblings of healthy individuals. And therefore, the age to begin the colorectal cancer screening actually also depends on the background risk of the subject. For example, if you have a family history of colorectal cancer or advanced adenoma, then you may need to start to have the screening earlier. So if the subject do not have any history of a family history, do not have any family history of colorectal cancer or advanced adenoma, and there's no other risk factor for colorectal cancer, including there's absence of inflammatory bowel disease. So according to the latest American guideline, they should start the screening at 45 years old. However, if you have a positive family history of colorectal cancer or advanced adenoma, and if the family history happened in a single first-degree relative having a colorectal cancer or advanced adenoma at the age of less than 60 years old, or there are two first-degree relatives having the same condition, then this subject is classified as having an increased risk of developing colorectal cancer, and therefore he or she should begin the colorectal cancer screening at age 40 or 10 years younger than the age at the diagnosis of the youngest affected relative. However, if the subject only has one single first-degree relative having a colorectal cancer or advanced adenoma at the age more than 60 years old, or only one second-degree or third-degree relative having a similar problem, then the colorectal cancer screening should still begin at 40 years old, but it can be just treated as FH risk screening. That means you can start with a stool test if the patient offers for a stool test instead of endoscopy testing. And however, if you look at the patient at risk of developing some hereditary cancer syndrome like FAP or HNPCC, and then you need to provide genetic counseling and earlier screening as appropriate. And so this slide is also summarize the performance of the current screening test. As mentioned by Hazen before, we have a stool-based test and also blood-based test. And for stool-based test, including the FIT, the overall sensitivity is around 80%, and there's a 95% of specificity for detecting colorectal cancer. However, if you have a positive result, you still require colonoscopy, and you need to be repeated annually, although the current colorectal cancer screening program in Hong Kong only suggests you have a FIT every 2 years. And for the DNA stool test, it has a very high sensitivity and a high specificity for colorectal cancer. However, the long-term reduction in the colorectal cancer incidence and mortality is currently largely unknown. And again, a positive result, you still require colonoscopy, and the repeat interval is currently unknown, but it's actually generally suggests that I should repeat DNA stool test every 3 years. And for some direct visualization tests like colonoscopy, of course, they have a very high detection rate for colorectal cancer, and it is reported to have a long-term reduction in the CRC incidence and also the mortality. However, you require bowel preparation, and there's a risk of complication associated with colonoscopy. And similarly, for flexible sigmoidoscopy, although we just examine the left side of the colon, it still have a very high sensitivity for detecting distal colon colorectal cancer. It is also associated with a long-term reduction in CRC incidence and mortality. And usually it is recommended to repeat it every 5 to 10 years. Again, if you find a tumor in the flexible sigmoidoscopy, the patient may also still require full colonoscopy to detect for any synchronous tumor and other polyps. And for CT colonography, again, it's very good for colorectal cancer. And however, the sensitivity for small polyps is a variable, and there is a very poor sensitivity for fresh lesion like cell-serrated lesions. And for colon capsule, again, if the polyps size is more than 6 nm, it's a good sensitivity and specificity. However, again, it requires bowel preparation, and it's positive examinations, the patient still require colonoscopy, and the repeat interval is actually unknown, although some studies suggest some guidelines suggest to repeat it every 3 to 5 years. And so what happens if a patient undergo a screening colonoscopy, and what should they follow the period? And so it depends on the core. Actually, for this question, it depends on several things. First of all, it's the quality of the colonoscopy, and the index colonoscopy should be of a high quality colonoscopy. That means the endoscopist should have a complete examination up to the cecum, and there should be adequate biopreparation to detect a polyp size more than 5 mm. And the colonoscopist itself should have a good adenoma detection rate. And then for the if he or she detect any polyp, they should have a complete polyp resection. And the other factor should be considered is about the number of polyps and the types of polyps that are found during the index colonoscopy. Usually, if you have a normal colonoscopy at the baseline, or just less than 20 hyperplastic polyp or small size hyperplastic polyp, you only need to repeat a colonoscopy every 10 years. However, if you found 1 to 2 small adenomas, then you should repeat colonoscopy around 7 to 10 years. And if you find 1 to 2 sexual-serrated polyps, then the subject should repeat a colonoscopy around 5 to 10 years. And again, if you find an increasing number of adenomas or increasing number of sexual-serrated polyps, or any adenoma with a villus or tubulovillus pathology, or even there's a high-grade dysplasia, if this is a complete resection, then the subject should repeat a colonoscopy in another 3 years. However, if at the index colonoscopy, the subject has been found to have more than 10 adenomas, then he or she should repeat a colonoscopy in 1 year time. So another thing is about the gut microbiome and the role in colorectal cancer. I think most of you have heard about it. It's a very hot topic recently. And so a few words about the gut microbiome. It's actually, there's 3 trillion symbiotic microbial cells, which are primary bacteria in our gut. And actually for our human body, the cells in the human body consist of 10% of the human cells only, and 90% of them actually microbes. And actually, if there's a dysbiosis, that means there's an out of balance of our gut microbiota. It can cause various health problems, including colorectal cancer, inflammatory bowel disease, obesity, autism, chronic pain syndrome, etc. And for colorectal cancer, at least 15% of our cancer are attributable to our infectious agent. And of course, it is a very important mechanism for the development of colorectal cancer, although it is not only caused by a single microbe. And so for the risk factor for colorectal cancer, there's a genetic heritability, which occurs in around 35% of the cases. And also there are different environmental risk factors, including our diet, high-fat diet, diet full of red meat without any vegetables, and also patients who are obese, who are active smoker, and who have a physical inactivity. All these are risk factors for development of colorectal cancer. And for this environmental risk factor, it occurs in around 65% of the colorectal cancer patients. And so from previous comparative study, it was found that when comparing patients with a colorectal cancer to a healthy normal subject, when you look at their gut microbiota composition, there's an increased abundance of several bacteria, including Fusobacterium nucleatum, Clostridium, and also Streptococcus and Streptococcus species, when compared to the healthy population. And one of the most well-known gut bacteria that have been shown to have a strong association with the development of colorectal cancer is the Fusobacterium nucleatum. And the other one will be the Streptococcus galolyticus. And actually, in a patient having a Streptococcus galolyticus septicemia, there's actually colorectal cancer is found in 70% of this group of patients. And so when we study, previously our group had performed a large-scale study exploring the microbial markers associated with development of colorectal cancer and also in healthy individuals. And we found that there are several bacteria which are specific for the development of colorectal cancer. And one of them, again, is the Fusobacterium nucleatum. So we have analyzed 490 subjects, including healthy control, those with advanced adenoma, and those with colorectal cancer. And you can see that the abundance of Fusobacteria is much higher in patients having underlying colorectal cancer when compared to the healthy control. And so we are trying to use this fusobacterial marker to test for their sensitivity and also their specificity in detecting colorectal cancer. And again, you can see that if we use both the fusobacterial marker together with the fit test, the sensitivity of detecting colorectal cancer actually improved from 73% to 92%. And again, recently, our group has developed a new fecal marker, which is composed of 3 different bacteria, and trying to use this as a non-invasive diagnosis of colorectal adenoma and cancer. Again, we find that we're using bacterial markers composing of 3 different bacteria. You can see that there is very good sensitivity and also specificity for developing diagnosis of colorectal cancer. And again, it's a quite good sensitivity for detecting adenoma. And besides, it can also differentiate. It can also detect both a long-advanced adenoma and advanced adenoma. By advanced adenoma, we mean those with a very large tubular adenoma, more than 10 millimeter in size, or those who have a tubulovenous pathology on histology. And so the good thing of this bacterial marker is that it can also detect adenoma, long-advanced adenoma, instead of just advanced adenoma and colorectal cancer in those usual stool tests. Yes, so this is what I just mentioned. And for traditional fit tests, the stool test, they usually fail to detect adenoma and early stage cancer. However, with the use of these bacterial markers, it's a high sensitivity in detecting those early stage cancer and also detection of a long advanced adenoma. And so for this stool test, so it can, this is just an at-home kit. So you just contain a container for a stool sample. And after the patient put in the stool sample into the kit, then it can ship to the laboratory for testing. And then from the result, it will give you a result whether you have a high risk of developing colorectal adenoma or low risk of developing colorectal adenoma. So if you have a medium or to high risk, and so we will advance the patient to undergo colonoscopy. And so there are actually now different molecular tests in the market for the detection of colorectal cancer. And so beside the one I just mentioned, there are actually other stool tests as shown here that you can go back and to study about this. And of course, beside bacterial marker, we have other microbial markers, which include the virus and the fungus, which can be added along bacterial markers for colorectal cancer. And we also have some blood-based markers. And as mentioned, Strep bovis bacteremia is associated with development of colorectal cancer, I just mentioned before. And there are some studies showing that actually the development of bacteremia predate the colorectal cancer diagnosis. This includes Streptococcus gallolyticus and also the development of Fusobacterium nucleacum bacteremia and Bacteroides vaginis bacteremia. All this has been found to predate the development of colorectal cancer diagnosis. And so with the advance in the gut microbiome technology, so we can now translate the gut microbiome in the screening, diagnosis, and also as a modulation of colorectal cancer treatment and a modulation for CRC prevention in the future. And so the gut microbiome actually play a very significant role in the colorectal cancer screening and probably also in the diagnosis, and also as a prognostic factor, etc. And so in conclusion, the time to begin the colorectal cancer screening should be determined by individual risk factor. And in Hong Kong, the colorectal cancer screening starts at 50 years of age in the FH risk population. And in FH risk screening, the colorectal cancer screening modality, including a stool-based test, this includes a guide-based fecal occult blood test or FIT or stool DNA test or direct visualization test, which include colonoscopy, sigmoidoscopy or CT colonography or colon capsule. And for patients who have a positive screening test result, they should be evaluated by colonoscopy. And in patients who have an underlying increased risk of colorectal cancer, the colonoscopy is the recommended screening modality. And there's an emerging role of a gut microbiome in colorectal cancer. So with this, we'd like to conclude a grand round here. So students, do you have any question? You are most welcome to type the question on the chat box. Thank you.
So if you have any question, you may just type in. So if you can think of, okay, how, there is a question for Joyce. How specific is the microbiome test?
So I think it's sensitivity, specificity is still around like, yes, as shown here. And so for the detection adenoma, the specificity is around 85% and the sensitivity is around 45%. And for colorectal cancer, it's also around 85%.
So any other questions? If you can think of any other questions later, you are always welcome to ask us when you see us, or you can send us an email. So if we cannot see any more questions from you, maybe we will just conclude the grand round today. And thank you very much for your attention. Thank you.
Thank you.